Compartment syndrome. This is a condition where pressure builds up inside the compartments of the muscle. This creates decreased blood flow, which can lead to necrosis of the involved tissue if it's not treated pretty quickly. Compartment syndrome can be acute or chronic. The focus of my report today is on acute compartment syndrome, which is usually due to some sort of trauma or a crushing injury, usually to a limb, a leg, or the arm involving a long bone. The muscle is made up of 4 compartments, along with vessels and nerves that surround the bones. The anterior compartment, lateral compartment, superficial and deep posterior compartments. This is where that pressure can build up. Imagine you're just standing around at work, and suddenly you're struck by something like a forklift. You're crushed between the forklift and the wall. Hard because forklifts move real slow. Ouch! You're taken to the emergency department where the nurse triages you and anticipates that you will need a few things. We're going to involve lab. We're going to draw blood and check specifically for muscle breakdown. We're going to get a CBC, a CMP, and we're going to check your lactic. We're going to get x-ray involved, radiology. I mean, you just got hit by a forklift. Something might be broken. So there we have lab and radiology. We're also going to make you a fall risk because your leg hurts. We're not going to want you walking on it. It's probably broken. Your pain will likely be 10 out of 10 because pain disproportionate to the injury is one of the primary presenting symptoms of compartment syndrome. We're going to check your pedal pulses, which might be diminished due to the injury of that leg, the reduced blood flow. And we might expect the doctor to use a needle gauge to check the pressures inside that compartment. Your pain's 10 out of 10, so we're going to be treating that with something like fentanyl or Dilaudid and probably Zofran because the pain can trigger nausea. We're going to anticipate your NPO and headed to surgery, so we're going to establish IV access. And then the provider's going to come in and he might primarily base his diagnosis on a physical assessment along with the mechanism of injury. The 6 Ps that can be used to help diagnose compartment syndrome. Doc's going to feel that leg. Like I said, it's going to be extremely painful. You might be experiencing paresthesia or like tingling or numbness, paresis, so a loss of muscle strength or weakness, and in later stages maybe pallor, diminished pulses, and poikilothermia, all from reduced blood flow. In emergent situations, the doc might just make the diagnosis off of that, the assessment, or he might use the Stryker needle to measure that pressure in the affected compartment. So you're diagnosed with compartment syndrome, acute compartment syndrome, and you're headed to the orthopedic surgeon for an emergent fasciotomy. The orthopedic surgeon will typically cut an incision on the anterior and posterior muscle compartments, depending on which compartment is under pressure. They're going to spread open that muscle to cut through the layers of fascia or connective tissue. This is going to allow more room for blood flow and helps reduce pressure in that compartment. The surgeon's going to check around for necrotic tissue and debride it and then work on sewing you up. But he's not going to completely sew shut that wound, but leave it partially open to continue to let pressure reduce and swelling come down. After about 10 days, it will be reevaluated. Diagnosed and treated quickly, the outcome is pretty good for a good recovery. We're going to continue to watch for muscle and nerve damage. Another complication could be rhabdomyolysis due to the breakdown of muscle. So we're really going to keep an eye on kidney function. And some of the poorer outcomes would be if treatment were delayed too long, the limb may need amputated, and left untreated, acute compartment syndrome could be fatal.